My name is Elizabeth Daly, and I am the Executive Director of the National Foundation of Swallowing Disorders. We're very excited to have you here this evening to learn more about how speech pathologists can use the MBSImP Global Registry to improve outcomes for people living with dysphagia. And while I suspect many of our 500 plus audience is familiar with the MBSImP, I think many of us are less familiar with the unique features offered by this registry. Before we begin, I want to thank those of you who have made a donation to the foundation. As a nonprofit, we rely on the community's financial support to further our mission. If you would like to become a member or make a donation, we invite you to scan this QR code here on the screen. And we would like to recognize Bracco Diagnostics for their unrestricted educational grant that allows us to continue our TAD Talk series free of charge. And I would also like to take a moment to recognize our educational sponsors who have helped make our webinar series grow significantly over the past decade. I also would like to thank Brooke at Tim's Medical University for helping us offer ASHA CEUs for this webinar, and I'll cover more on that here in just a second. For those of you who have not previously joined our virtual events, please note that you will be muted throughout the presentation. We encourage you to ask questions at any point during the presentation using the question box in your GoToWebinar toolbar. There will be plenty of time reserved at the end of this presentation for your questions. This event will be recorded and available to view on demand within the next 48 hours. For those of you who are interested in ASHA CEUs for your participation, please note that these are only available for tonight's live broadcast. Following tonight's webinar, you will receive a survey, and it's required that you complete this survey by November 11th in order to receive credit. For those of you who complete the survey but do not need or want ASHA CEUs, you will be provided with a certificate of participation. And now it's my pleasure to introduce this evening's expert speakers, Dr. Bonnie Martin-Harris and Kate Davidson. Dr. Martin-Harris is a professor at Northwestern University and the director of the Swallowing Cross-System Collaborative Laboratory. She is internationally recognized for her pioneering research on swallowing and respiratory coordination and for developing the modified barium swallowing impairment profile, now used in clinics and universities around the world. She is a past president of the Dysphagia Research Society, recipient of ASHA honors, and a leader in advancing evidence-based care for people with dysphagia. Speech-language pathologist Kate Davidson serves as a research associate at the Medical University of South Carolina. Kate practices as a laryngology advanced practice provider in the Department of Otolaryngology, Head and Neck Surgery, managing patients with airway, voice, and swallowing disorders. She also serves as assistant director of the Swallowing Cross-System Collaborative at Northwestern University, where she leads interdisciplinary efforts to advance dysphagia research and care. It is an honor for the foundation to host both of you this evening, and thank you for volunteering your time. I will take a quick second here to make you the presenter. Hang with me for just a second. All right. Kate, you should see the option to share your screen now. Wonderful, we can see your screen, and yep, now we can see your slides. Fantastic. Thank you. I'll let you take over.
That's great. Well, thank you everyone for joining us. I'd like to say a big shout out to Ed Stager and to Elizabeth Daly for all that you do for our profession. Thank you, thank you. I just got off the phone with a head and neck cancer survivor 10 minutes ago. You're making a huge impact. So today, and I get the pleasure of working with my colleague Kate tonight, which is fun. And what we're going to do is talk about the MBSImP Global Registry and how to implement this into your daily practice. So Kate, I'll let you drive.
These are disclosures.
Thank you. Okay. So we thought what we would do is, it's hard to talk to something out of context. So we're going to bring the global registry into a short introductory context. And this was all based on a foundation of how swallowing works and keeping up with the science that swallowing is not something that occurs in these discrete phases that are somewhat arbitrary, but it's a synergy of physiologic activity from mouth to stomach. And it was really important to me early on that we had a method of not only observing this mechanism, but also quantifying it and reporting on it and communicating on this mechanism. Okay, Kate. And so it's important when we talk about the MBSImP data registry to realize that the data are extracted from field clinicians who are performing modified barium swallow studies using video fluoroscopy. Some people interchange the terms, that's fine too. But the purpose of an MBS is to identify the type and severity of physiologic swallowing impairment. Yes, to identify the presence of aspiration or airway invasion, but also the cause. Because one of the main reasons to do this diagnostic is to direct your treatment. And that's always what was of interest to me, not just to be a diagnostician, but to have meaningful, clinically valid data that I can then use to help guide my treatment planning. So the MBS really provides information, surrogate information, pretty good information about the sensory motor underpinnings of the swallowing movements. We have a lot of data now from, manometry, simultaneous manometry, et cetera, and other simultaneous studies that really provide very good information or give us a very good impression about how swallowing is working by looking at modified barium swallow studies. It's not everything. It doesn't tell the whole story, but it tells an awful lot. Okay, go ahead, Kate. And it's really important, and many of you have heard me say this for years, but that we get beyond just focusing on the bolus and residue and aspiration. While these two signs of risk are very important, they do not tell the story as to the cause of the problem and how to direct your management. So we wanted a method that would not only look at this, but also look at the movements of swallowing related to bolus flow. Okay, thanks, Kate. We knew back then in the early 2000s that there was a lot of variation in practice. So it was hard to quantify observations if there was variation in the protocols that were used during MBS, the materials that were used, the instructions that were given, the positioning of the patient, let alone the metrics and the observations, and also the validity of the measurements that were used in the examination of the results. So we really wanted to develop a method that would help us get closer to solving some of these problems. Okay. This work was originated, but with an NIH grant, and that has continued from the beginning. And a lot of these grants incorporated mentorship as a part of these grants because I felt it was really important, not only to study the validity of the measures that we look at, but also for me to learn how to measure these things psychometrically and also to mentor others to do the same. Not only speech pathologists, but physicians, residents, fellows, etc. Thanks, Kate. The first study that we did was in 300 people, and these were all patients who were referred for modified barium swallow studies at two centers, MUSC and St. Joseph's Hospital of Atlanta, a community-based hospital. So it's important to understand that when we did this study to try and validate not only the protocol, but the actual measures, that I was always thinking strategically that whatever we came up with would facilitate data entry by field clinicians, because I've always been a field clinician throughout my career. And I wanted it to be meaningful, not only to me as a researcher, but as the clinicians who were actually collecting their own data. Thanks, Kate. This was extracted from our first study. These are the components that we look at. 17 things, and when Kate talks about how we enter the data in the registry, this is the primary data that are entered, the scores, but much more than just the scores, because we understand that a patient is more than just physiology. There are many other contextual factors that go into how we manage the patient. So, okay. This is the scale that we use. It is the scores that go into the database are overall impression scores, which are the highest rate of impairment across 11 swallows. There are a lot of reasons why we selected that method psychometrically, and I'm happy to talk offline or later with anybody who wants to talk about that overall impression approach. But what it was our goal to capture severity on each of these components using a scale that was as unambiguous as possible with the human eye. Thank you. So what we did was we standardized the protocol and we validated it. So what we've learned is that we used standardized, commercially prepared contrast materials. We used Veribar. And the reason we did that is because we wanted to be very transparent in what we were doing in the study with the patients, and also wanted the results to be replicable. So early on, even in the 300 subjects, Veribar had just been introduced, and we were fortunate enough to use it during our initial validation studies. So we validated the protocol, we validated the tool, and we worked on standardizing how we operationalize this in a standard report. If you look, fast forward to the future, last year, the Academy, or the American College, sorry, of Radiology finally updated their practice parameters for modified barium swallow studies. This was done by a reading group and a writing group through the Society for Abdominal Radiology, and I was fortunate enough to participate in this, but they took some of my recommendations, not all of them. But what you can see is that they call for validated standardized methods in their practice parameters. And they also call for standardized consistencies for safety issues, for replicability issues. They also standardize or recommend standardized fluoroscopy rates, that is continuous fluoroscopy or 30 pulses per second, always being cognizant of as low as reasonably achievable, our LAR principle. And we want to make sure that we're observing mouth to stomach. Thanks, Kate. The ACR guidelines also say that the swallow study should be reviewed by the performing team. You should discuss and collaborate your findings. You should be able to compare to prior results. So you'll see when Kate demonstrates how we use the registry, you're able to look at results from one study directly next to the other study to see how a patient has changed. A radiologist and speech pathologist ideally collaborate or corroborate their findings, and recommendations are made by both, excuse me, in terms of care planning. Okay. We also wanted to come up with something that would be refinable based on input from clinicians. And we do take the input and we refine. We totally updated the website to make it more accessible to clinicians, more readable, updated high resolution images. Shout out to Tim's because we used ICOM images because it's now available. So we actually got an award for this website because it was so clinically practical, and the widespread uptake that it's had. Okay, Kate? Including the database. So this is what the current website looks like. When you input your data, you will see how it gets extracted, and Kate's going to show us that in a little bit. We have If you go online, and Kate's going to show you, you're going to see a standardized report that is now available. So clinicians, as you all know, go in and take standardized training, and the purpose of that is to maintain the validity of the instrument. So, and we update that with new science as it comes. We have places on the website with all the new references. And so what clinicians do is they learn, they train, and they test. And then they test to a certain threshold of reliability. Even though that reliability doesn't sustain forever, you have to practice and calibrate with your colleagues. It does facilitate this reproducibility of results or reliability. Okay, Kate. This is what the report generator looks like, and we're going to take you through exactly how to enter the data to give you this report. You see this nice head, and what it does is every location is a location of where that score occurs, and the label that's applied goes on to the report. And physicians seem to like this, as well as other care providers. We now have a TIMS DICOM scoring interface where clinicians can input their scores at the time of their exam into their workflow after they've had a chance to review. And again, we're going to see a demo. Thank you, Kate. This is the registry. We call it the Swallow Data Registry, where the scores are input by the clinician, de-identified, completely HIPAA compliant, not even under the purview of HIPAA, because there's no privacy information. We do have some basic demographics that have to go in to generate a report, but many, many other data points you have available to you to enter if you'd like to retrieve them for your own reporting. Okay, Kate. I mentioned uptake. You know, we couldn't be more pleased with how many clinicians have adopted the MBSImP. We now have over 10,000 registered clinicians. Those are clinicians who have trained, registered, and now are able to put their data into the data registry. We're in 45 countries now. Elizabeth mentioned universities. We're in 158 training institutions. And I hear from clinicians and instructors all the time, which is, you know, heartening to me. And really what this talk is about is 139,000 swallow studies that we now have in the data registry because of clinicians like you who are inputting and contributing to our knowledge of dysphagia and the various profiles of impairment across diseases and conditions. Okay, Kate. We've also retested the validity of the tool. Our wonderful colleague, postdoc, Dr. Alex Klein, led this study where he, rather than validate this tool based on our initial 300 patients, it's been validated and internal consistency, and rate of reliability were re-examined in over 52,000 swallow studies. So we're feeling pretty good about the fact that the validity and reliability of the tool remain. And we use this SDR database for data-driven research. So we're in the world of big data. We had a vision for this before it even was a term. It's enabled us to characterize physiologic impairments by diagnosis. We also want to, in the future, characterize changes in swallowing patterns or profiles of impairment by disease progression and treatment, and also characterize how changes impact sequela. Those are projects down the road. Okay. This paper that we more recently published, 2024, I think, I can remember, can't see the print, where this was a paper led by Alex, and we characterized physiologic swallowing impairment according to patients who were in the category of head and neck cancer, stroke, pulmonary pulmonary disease, dementia, and Parkinson's disease. So that's just the front of that paper that was in JSLHR. We looked at 52,000 patient records, and then when we looked for diagnostic categories for this particular study, it was based on over 8,000 patients, and you can see the numbers in each of the patient groups there. We looked at the 17 components. We also looked at penetration aspiration scale scores. We used PAS max in this study. That's the highest across the swallows. And I know there's a lot of discussion about that. I'm happy to talk about that as well, why we chose that. And this is what the different profiles look like. So these are string graphs, and every graph represents a different diagnostic category. So you can compare a pattern in one group to another. We see similarities for sure, and we see others that stand out in terms of severity, like you might expect with head and neck cancer. So we've generated hypotheses from the data. So you don't go into all big data with hypotheses. You hope to gain hypotheses from these data. So our hypothesis that shared profiles may represent common baseline impairment across diagnoses. The uniqueness of the impairment profiles seem to differ by diagnosis. And then there are multiple impairment profiles that can result in risk of aspiration penetration. So those two things don't stand out as separating the groups, if you will, because many of these patients have aspiration and residue for different reasons. Let's look at a specific patient. This is an 80-year-old patient with dementia. And this is what an individual personalized plot can look like. We call this the MBSImP plot that's being added to our report functionality as we speak. And it plots the score of the components in a normalized fashion over each of the components. So it becomes a characteristic pattern, almost like an audiogram. And then we can plot it to other patients like that patient in a dementia group at that particular age and compare the expected versus where your patient is. Okay, Kate? Sorry. And then finally, this is a new paper. Hopefully it'll be presented at GRS maybe. And this is where we're taking the oral scores and the pharyngeal scores, and we've created percentile rankings. So you can compare your particular patient's performance along a percentile of performance. So your patient is functioning within the 75th percentile, for example. Okay.
All right.
You, Kate, you can take that and you can drive, okay?
Perfect. So Dr. Martin-Harris has kind of given us an overview really of the integrity of the data that's going into this SDR, right? So the standardized training and reliability testing, the maintenance of the reliability training to continue to input data into the database as a clinician, and then shown you from a global standpoint around the world, this large database of now 140,000 people. But again, that study that Dr. Clayton performed with the, I think about 5,000 patients from the database with these profiles. So that is very high level, big data research using the entire global data registry. But what I want to do now is take about 10 minutes to show you as a clinician how you can use first our integrated TIMS scoring interface to input data into the data registry. If you don't have TIMS, I'll show you how to do that without a TIMS DICOM unit or MVP, and then show you how you can query your own data for your own institutional level projects, querying patients from all of the clinicians within your institution or facility, and show you an example of how we did that at the Medical University of South Carolina for a DRS talk a couple of years ago. So I think there might be a delay between the audio and the video, kind of just based on my experience just now. So if what I'm showing you on the screen does not quite align with what I'm saying, I do want to put in a plug. We will be at the TIMS booth during ASHA. If you're going to be at ASHA, and I can't remember the specific date, but stop by the TIMS booth to see. We will be doing a live demonstration like this at their booth as well. So I am going to switch over now to, this is sort of a pre-recorded screen recording of me going through this whole process, just to ensure we didn't have any technical failures with me being on VPN and remoting into my work computer. So what you're seeing right now on your screen is TIMS MVP. So if you're fortunate to have a system like this at your facility, TIMS is both an acquisition and data analysis and report generating type system that we use for recording our modified barium swallow studies in DICOM format. So very quickly, I'm not going to be able to show you all the features of TIMS. I'm really focusing just on the scorecards and inputting data. But there are some great features, a few that I'll highlight for that I use when I'm scoring a modified barium swallow study. So the first is labeling the swallows. For me, it's important to understand how the patient's performing across different bolus volumes and consistencies, even though I'm deriving my overall impression score from all of those swallows. The MBSImP guide provides information from studies that we've done that tell you which consistencies actually are more likely to result in an OI, or the highest impairment score. So that facilitates quickness with which you can score your study, of course, in a hectic clinical environment. So being able to appropriately label as you're acquiring images or after to know which consistency you're scoring. So I'm just showing you this up here at the top of the screen is where that is labeled. Our label set is the MBSImP standardized protocol. If you don't use the MBSImP standardized protocol, there's a way to build out your own protocol. And then on the left side of the screen, you see these little images. Each of these are an individual swallow. So for MBSImP, I have 12 individual swallows that I can scroll through here. And then, but the highlight and what we really are here to talk about is this MBSImP scorecard. That TIMS has a number of scorecards, and I'm going to start playing the video now, so I may start kind of being a little bit off from what you're seeing on the screen, but it also includes digest and PAS, etc. The scorecard is nice. If you hover over a component, say lip closure here that you're seeing, it's showing me when to score as a nice reminder, and then I get a drop-down list of each of the component relevant scores for that component, plus a description of that component score. So you don't need to pick up your MBSImP component score definition sheet and reference that while you're trying to score. It's all right here in this one compact system. So now you're just going to see me kind of start scoring the study, working through each component. TIMS will let you move frame by frame, forward and in reverse, and it's really important because we don't score in real time. We like to slow down and look at how the individual structures move relative to bolus flow, looking for very specific time points for assigning a score. So that's one nice utility of TIMS, allowing for that frame by frame review. I'm on bolus preparation now in the video here. I'm going to skip over that because I'm kind of just going through the components on this particular swallow. But what I want to show you is coming up here in a second. I'm about to score swallow at pharyngeal swallow initiation. And to do that, you have to look at the leading edge of the bolus, where its location is at the time of first brisk, anterior brisk hyoid movement. And so TIMS does have this annotation feature that will allow you to kind of draw on the image. I like to use this vertical line here to help me focus my eye and really accurately identify when that first brisk movement happens. And so I'll wait until I see the hyoid kind of cross that plane, and then I'll mark my score. If you are not entirely sure about where the leading edge of the bolus is, and in this one it's a little bit difficult. Is it at the angle of the ramus? Has it gone into the vallecula? I can do the same here just to confirm visually that the bolus has not entered the vallecula, and so I assign a score of 0. So this is going to move kind of quickly now through the remaining components. You're watching me score in real time, but I've sped it up just so to keep this in a nice 10-minute window for tonight's webinar. But I'm going back now and I'm about to finish my AP view components. And then once I do, I have a full MBS. I have all of my 17 component scores here. I'm going back and checking a few. And what TIMS does is it provides this nice heat map, and you can see the color ranges kind of at the top of the scorecard there. And this heat map is kind of showing me, going to direct your vision to, well, where is the impairment? And for this particular patient, I'm seeing red kind of in the component 17, more in the oral cavity, not so much in the pharynx. And if I click on results, this is taking me to the pharyngeal total score and the oral total score that you would see if you're doing your overall impression scoring and deriving those scores. And I do see in the heat map that really I probably need to focus on some of these oral problems and maybe a referral to GI for this esophageal issue. Just a quick heat map look at that. So that's a nice feature of TIMS. But what we're really excited about and what we collaborated with TIMS on was finding a way to push this data directly to the MBSImP website so that, one, you can contribute to the data registry, which is moving research forward and helping us learn more about dysphagia in general, but also so that you can have a nice report to copy and paste into your medical record. So what you see me here is putting in the very minimal information that's required of the MBSImP website to generate a report. And what you saw me just do was send my scores without creating a report initially. If your workflow is to not use the MBSImP report generator and use the TIMS report generator, at that point you would do that. But here I'm now demonstrating going back into the system, selecting the patient, and now I'm going to push my scores and open up the MBSImP website, and it pulls the window up for you. You log in again, select your institution, and this is the report that it's just created. So what you see is what we demonstrated earlier, where there is just the basic demographic information. You get the MBSImP kind of head that shows you the location of the component scores, the MBSImP narrative that's derived from the scores that you input into the table here. Because this is this patient's first study, I only have the current score and descriptor, but if I was comparing this to a prior study, you would see the previous study results in this table as well. And then you get your oral and pharyngeal total scores. And so after that, you're able to either download a PDF format, you can download a Word document to edit it, or you can go ahead and print the report if you're going to be scanning it, say, to a physician in an outside facility, or you can go back in and edit your study data. So what you're seeing now is the full standard report generator on the MBSImP website. If you did not have TIMS DICOM, and historically we did not, I would have this pulled up on my computer, split screen with whatever feedback or review software you have, and I would put my scores in directly to the website with the secondary player, so I could see the video. But because our scores are already in, you'll see that in a minute, I do have the option to go back in and fill out this more detailed information. This includes as much or as little information as you want to put in your report. So we tried to think of everything you could want, but you certainly don't have to use it all. So you see things like patient's height, weight, it'll calculate a BMI. You can indicate if the patient's had prior treatment, if they have a trach tube, or if they're ventilator dependent. There are pre-study statuses, so their intake status, are they PO, do they use a PEG, what type of study diet grade are they on, so regular, mixed, soft, or you'll see we do have the ITSE scores later down that we can now with the more standardized ITSE nomenclature. So you can enter your FOI score, so your functional oral intake scale score up to 7. There is a place for you to enter any clinical notes that you might have that you'd like to include in your subjective of the patient. We have also included our patient reported outcome measures, so you see them listed there, the MD Anderson Dysphagia Inventory, Dysphagia Handicap Index, and the E10. And we're constantly receiving feedback from clinicians and refining this report generator. So if there's something here that is missing that you use frequently, reach out to us. We're happy to take a look and consider including additional tools or other patient-reported outcomes. You can also indicate study-specific information like the pulse rate used, the patient positioning. You'll see that because we've pushed our scores from TIMS, I don't have to re-enter my MBSImP scores. They are already there. Had I used the PAS scorecard, you'll see that in a second. So those penetration aspiration scale scores can carry over. What just popped up on the screen here is these individual swallows. This is specific for research. So clinically, we're using the overall impression score, but for research, we do swallow by swallow. So if you're using MBSImP data registry for a research project, we do have the ability to do a swallow by swallow scorecard or data set for you. One of the nicer things that I do like about this is the ability for clinicians to pick the components that contribute most to the patient's impairment. And so what you see on the screen now is that particular section of the report. You pick up to 5 components and you can indicate what the component was and what its contribution was to impairment, or what sort of outcome, a functional consequence or outcome from that impairment, and that'll put in a nice little table in the report. I can also list any structural abnormalities and their impact on swallow function, and that will generate another table as well. And then I can indicate now our post-study information. So PO status, diet grade using ITSE, our post-study functional oral intake scale score. I can put in any additional clinician notes or assessments, any nuances that I want to describe in the patient's report. And then a really nice, relatively newer feature, and by new it was probably within the last 5 years, but we have added in the ability to evaluate and plan compensatory strategies and therapeutic strategies or endeavors. So here you're seeing me indicate if I used a head turn, what its impact was, and did it influence any particular outcome. So you can see those listed there, again, as inclusive as we could be. And then those therapeutic endeavors. So do I want to have the patient participate in structured therapy? And you can see those traditional evidence-based therapy approaches there. Are there any referrals to other specialties that we need to make? And for this particular patient, we did see that they had a esophageal clearance score of 4, so we're indicating that there. We're going to initiate therapy, and then again, the clinician's written assessment of the study can be entered here, as well as prognosis for improvement and the patient's personal goals. And after this, we have this sort of radial dial click to go through long-term goals and short-term goals. And what this is going to do is it allows you to build goals and build them in sort of a narrative form. So you see me selecting long-term goals here. And now I'm going to select short-term goals for diet. So you're seeing, yes, I want them to start PO intake. This is the type of diet I want them to have. And then what % of the time do I want them to tolerate that diet without signs or symptoms of aspiration penetration? And if they're going to work with an SLP with PO trials. And then I can do the same for anything you see in this list. I'm showing in the demonstration here, though, structured therapy. So we're going to start an effortful swallow using SEMG. I want the patient to perform with 80% accuracy and minimal cueing. And then you'll see in the report how this puts this into a nice narrative format for those goals. So then you click report view, print or download, and it's going to pull that up. Now, this isn't a perfect report because I didn't really get into the subjective or really fill out the medical history because this was a quick demo, but that would be a much more thorough report if you were doing this clinically. But again, you can see the head and the scores because I did select very quickly the swallow by swallow for research. If you're interested, this is what that swallow by swallow table looks like. You see our structural abnormalities, the assessment, our plan now where you see our diet grade with our ITSE levels listed, our referrals, our therapy recommendations, And then those short-term goals that we worked, that we used our radial dial clicks to come up with a nice fully thought out goal for this patient that we can change on subsequent reports going forward. So again, you can download this, you can edit it, or you can print it. This is a quick view at if you're in a hurry and you don't have time to fill out the full standard report, or if you have something built into your EMR that you use instead, but you want to just communicate using the report generator, your MBSImP table. This is the express report. So you're seeing just kind of the bare minimum of things that we thought, at least for the data registry, we would need in a standardized report to help us make some inferences about patients' performance and outcomes, etc. This is the data registry. So you can see this is, I'm just pulled into my account. I can see all the studies that I've ever done here. In this list, they're organized by that de-identified patient ID. I can see how many studies they've had, when the most recent study was, and who was the clinician performing the study. Now this is again set to me, but what I can do is I can sort by everybody in my group, and I can see all the modifieds at MUSC, and then I can query all of those studies that have been entered. So I'm just going to show you really quickly something you might want to query. I'm looking for patients between 2016 and 2017. I want them to have a primary diagnosis of Parkinson's disease. And so maybe I'm just doing a little side research project. I could enter comorbidities and past medical history. I'm interested in patients who have tongue-based scores greater than or equal to 2 and pharyngeal residue scores greater than or equal to 2. And then again, there are other things that I can enter, like did patients have scores that improved in a later study? But I want to see patients who have initiated therapy at this point and who are using a chin tuck. Again, other things you can put in are related to pre and post study intake route and functional oral intake status and your basic demographics. And then I hit search, and this returns all of those patients that meet my query and organizes them again by patient ID. I can see the number of studies. These are their component scores. It's going to give me those basic demographic information, our pre and post study intake status, any patient reported outcome measures that might have been entered, any compensatory strategies or therapeutic endeavors included with these patients. And then I can export this very quickly into an Excel spreadsheet, so a .csv file that I can then upload to REDCap, or I can send to a statistician, or I can into any sort of statistical software I might use to answer any questions or hypotheses that I might have about patients at my facility. So stepping back from that and just really quickly showing you an example of how we did this at MUSC. It's just some quick ideas here if you want to screenshot things that you can use the query function for. This is for outcome tracking at the clinical level. So for example, monitoring diet progression or therapy response over time. Tracking MBS follow-up completion rates. You could generate site-level dashboards for internal auditing or quality improvement. For clinical research, you can identify cohorts by diagnosis, impairment, or outcomes. So kind of like the example I just showed you, or a head and neck cancer patient with PES opening greater than or equal to 2. You can evaluate pre and post intervention effects, examine relationships among physiology, or the interdependence of MBSImP components. And that's exactly what we did in this example that we presented at the 2017 Dysphagia Research Society. This came from a clinical question or clinical finding that we noted in our patients and had some curiosity about, and wanted to know if we could change our practice, our interventions with patients to make a difference in individuals who had absent anterior hyoid excursion and poor PESO opening. Could we better target PES opening in these patients? So we know PES opening kind of has a combination of things that are required to happen for it to be successful. The first is that tonic inhibition of relaxation of the cricopharyngeus muscle. kind of out of our control as speech language pathologists to intervene. Higher laryngeal mechanics, so laryngeal elevation, component 8, and anterior hyoid excursion, component 9, to move the larynx anteriorly up and forward, pulling the cricopharyngeus open once it has relaxed. And then the third is bolus propulsion. So really that, or interbolus pressure, that drive behind the bolus to push it through the UES. And that's from those pharyngeal contraction type components, tongue-based retraction, pharyngeal stripping, pharyngeal contraction. And so what we were noticing in a good number of our head and neck cancer patients was that they would come in and they would have absent laryngeal elevation or hyoid movement from, you know, fibrosis over time, these toxicities of the radiation that they underwent. And some would have absent tongue-based retraction, but they were still somehow achieving this PES opening. And what we noticed was, and you can see in this example, they either had complete or partial pharyngeal stripping. So that drive was still there to drive the bolus through the PES. So that was, you know, so these arbitrary like things that we were noticing are anecdotal, but we wanted to really test this hypothesis that preserved pharyngeal stripping wave could facilitate PES opening in patients with impaired higher laryngeal mechanics. So just like you saw before, I just opened up my MBSImP account. I went to the query section and I queried those patients that had absent laryngeal elevation and absent hyoid excursion. And we dichotomized those scores from that query. This was between 2011 and 2016. It came back with about 3,000 patients for my institution. And this is just kind of the breakdown of how we subdivided into those dichotomized groups. We ended up with about 1,600 patients. You see the breakdown there from male to female, and our average age was 64. And what we found, and it met our hypothesis, was that in patients with impaired higher laryngeal mechanics, so either partial or absent, the odds of having complete PES opening was higher when there was complete pharyngeal stripping wave. And so how did this change our practice? Traditionally, we were in line with sort of those traditional approaches to managing impaired PES opening, surgical Botox, episiotomy, working with a laryngologist there, compensation using like a head turn or a chin tuck, and our motor or intervention, our exercise-based suprahyoid strengthening and flexibility, like the Shakir or CTAR, and doing the Mendelssohn. But from this, we really started targeting pharyngeal stripping as well. So adding to our regimen of exercises in these patients, things like the Masako or tongue hold maneuver to help anchor that tongue anteriorly to really improve that superior pharyngeal constrictor to help drive the bolus through. So just a quick study, didn't take a lot of effort because the database was there. The query was easy to run for us to see, to confirm our hypothesis to help make clinical change in these patients for the type of programmatic exercises that we were giving them. So I'm going to kind of bring Dr. Martin Harris back into it. We'll close this out just to talk, summarize kind of what this, from a high scale, big data perspective, all the way down to what you can do as a clinician, really transforming those MBS exams that we're so grateful that our SLPs around the globe continue to put into the database, the searchable database that we can use for benchmarking and research.
Thank you, Kate, so much. So I think, you know, you can see a very detailed use of the database. It can be as big as you want it or as small as you want it. You may not know this, but we have actually had all the database up since we first introduced the MBSImP online, but we've refined it over the years. In fact, when we first did it, we had ICD-9 codes in there. Now we've updated them all to ICD-10. So we've constantly refined it. In my school, we have something called scientific play that my dean likes to use. I would highly encourage clinicians to go into the database and play around with the functionality and see how you might be able to, one, personalize it for your patients, and also operationalize it for your own benefit and the benefit of your colleagues. There's a lot there. Goals are written for you. Strategies, everything we could think of, we put in that database. Couple caveat, you know, this all started off with scores and the other clinical information, but it is really important that you maintain the integrity of the data that goes in by being like trained within your, you know, code of ethics. We're not the MBSImP police, and so I don't own it. The university owns it. But when you go into TIMS, you should acknowledge that you at least have taken reliability training and you can put scores in. And in fact, you can't transfer your scores if you're not MBSImP trained, because that would disrupt the whole validity. And just a little plug for the protocol, because it's 11 swallows. We have found that with those 11 swallows, no one consistency has a higher probability of capturing overall impression scores versus the others. So we've included them all. You can add, but by using that standard protocol, we maintain a radiation safety dose, according to Heather Bonilla's papers, of 0.27 millisieverts, which is like very, very minuscule. So this all starts at the beginning with training, with capturing the right data, entering the data, and then it's endless. So not only is it informing you in your practice, but it is informing the field, because you see the type of research that we're able to do with that data with you as participants, like clinician scientists in the field. So thank you so much for your attention, and we're happy to take some questions. I think, Elizabeth, we have some time.
That's excellent. Bonnie and Kate, thank you so much for sharing this presentation with us. It's remarkable how much work and effort has gone into this, and I'm sure how much work and effort is required to maintain this and keep up with everything. I'm going to start with some questions here. One saying somebody is MBSImP trained, is there a way to get access to using the reporting feature online, or can they just log in and do that?
They just log in.
Okay, excellent.
Yeah, it's there for you now.
Perfect. Is there an estimated amount of time that it takes for filling out the express report? There's a concern from management about how long the note writing takes.
Kate, I can answer, but you answer first. How long does it take you?
Maybe 10, 15 minutes.
Yeah.
Even and with TIMS too, it goes even faster. But yeah, I don't ever spend more than about 15 minutes on a report. I think sometimes as clinicians, you know, and I tried to kind of show and demonstrate, you know, my process for scoring, which is to kind of look at the whole swallow study, of course, score single swallow, and then very quickly scan the others, viscosities or consistencies to see if there's change, and of course using the MBSImP guide to kind of target those particular bolus trials that do create or have a higher likelihood of giving you the OI score for a particular component. So the scoring itself and then the note writing, 10 to 15 minutes, nothing more.
Like anything, it depends on the severity of the patient, right? So it's always harder to score certain patients than others, but the actual inputting the data in the report, Kate, pretty quick, right?
Mm-hmm. Yes.
Yeah. So you would imagine it gets faster the more you do it too. The more
we also say that it's almost all radiodial and drop down. So there's very little free text. You can free text, but each thing that you press turns into text once you print the report. So it's fast.
Really quickly, oops, I stopped my camera. I wanted to share just to show our last question, or the first question we had. This is the MBSImP landing page. This is where you go in, you get your training, you do your testing. Once you complete your testing, then this patient data reports is open to you, and that's what you click to get to the patients there, and you would just add a new express report or add a full report.
While you're there, Kate, there's another question of somebody asking if there's a repeat study done, how does the report generator connect a study to the prior one?
It's a great question.
Good question. Yeah. So if I add a new patient, I can either generate a new patient or I can search for existing patients. And I would just need to know, which you would do with your thorough chart review before seeing a patient for a modified, what their last MBSImP ID would be, and that's going to be included in the report. So when you generate the report, it's at the top of that report. So you would just copy and paste it, and then you can hit search. So you enter a partial or full patient ID and search for them, and it will bring that patient up. And it does it as well on the TIMS side. So TIMS will also prompt you, is this a new patient or a repeat patient? And you would put that unique ID in for them.
And you know, Kate, too, with in a situation like that, the side-by-side feature. So in the Express report, you can have you'll have the scores from your current study compared to the scores in your previous study. So it's really nice to be able to demonstrate change.
Mm-hmm.
In the report, then, does it comment automatically on that change, or is that where a clinician would kind of free text?
So your table, yeah, your table, I'm gonna pull somebody up. Your table will show you a pre and post score, and then you as a clinician would want to comment on that. It's nice to have these things sort of automated, but we don't want it so automated that it takes out the clinician's ability to think about and make an assessment about the patient. So let's see if I do.
While Kate's looking for that, the other thing is every time a score appears in a report, it's defined, because it's not very useful to just show a bunch of numbers to a, you know, to hand off to somebody, but they're all defined so that a patient could say, okay, that's a 3, this is what it means, a 2, this is what it means. And then this time they got a 1 versus a 2, so the patient's progressing.
Mm-hmm.
Really. Yeah.
So this is what it looks like. So you have your see if I can make it bigger. Your current score. So this is the current. Now this is fake. These are test patients. This person didn't get that bad that fast. But this is your current score and descriptor and your previous score and descriptor at the time of their last study. So I can look to see, okay, well, this person's tongue control got worse and their bolus prep got worse and their initiation got worse. So maybe this person has a progressive neurologic disease that's causing these changes. Again, this is not a real patient. This is just me developing some examples, but yeah.
Excellent, thank you. Question, how often should an SLP be recertified on the MBSImP?
Great question. Currently, we have a 5-year renewal, a 10-year renewal, and a 15-year renewal. If you can believe that. We know who the first person is. It's going to be recertified. Kate.
No, we need to make one when I get the notice.
You know, we do this for your. We really do work on these renewals. Our feedback has been really good because they're really meant to be educational and not punitive in any way. We set you up to be current in what's happening, to recalibrate your thinking on hard to score kind of items. So please don't be afraid of it. It's a way to just kind of keep up the whole validity of the method. So yeah.
Mm-hmm. Excellent. We have a question about the baby VFSS IMP. Wondering if it has all of the same capabilities and if there's a protocol that's available in TIMS, kind of one of those scorecards.
It's a great question. You must have telepathy. So we decided to put baby out there before the report was done because we really, you know, we learned from the adult side. We want input from clinicians and we're getting it, which is fabulous. But I can tell you the report has just been drafted and it's done. So Northern Speech is working with, they're called DDA, to input the report onto the website. So we will be able to do something very similar. It'll be a little bit more condensed than the adult because as we learn, we'll grow it, right? As clinicians say, please put this tool in there, we'll add it. If it makes sense. And so TIMS is also developing their scorecard on the TIMS unit for baby. It's coming.
Okay, excellent. I see somebody is clapping in the audience here with their emojis.
We're trying. Shout out to Maureen, to my colleague, left and right.
There's a clarification question here. Can you compare the scores in the registry, the data that's there, with just your institution, or is it any clinician that's entering data in the MBSImP?
Great question, just your institution. And But I can tell you that I have a goal. We have a goal. Our team has a goal, and we've been trying to strategize this. So right now you can only see your institution's data. My goal is to make the data registry open to anybody. You have to be careful. There are nuances associated with that. You know, we're in an area of open science and we'd like to have things accessible. There are different ways of doing it, and we're exploring that now. Like, you can publish various versions of it. So we're working on it. Right now, no, but that is definitely a goal, so that anybody can use it, ask questions of the whole database. That will come.
Excellent. I love that. Speaking of things that are to come, how is AI and machine learning affecting BFSS?
We specifically didn't talk about it tonight, but we do have a project. We're 3 years in, and it is a machine vision project. And the results aren't in, but what we're looking at is more of a scoring companion, a collaborator for a clinician to help collaborate an algorithm's findings with your findings. So it's not in any way meant to substitute the clinician, but to help them pay attention to certain aspects of the swallow. So they're all, and you know, we really are excited about our decision making. So it's coming. It takes time. People think, I have had so many emails, oh, this is great for AI, blah, blah, blah. You can take a black box approach, but you can also get out a lot of noise. So you have to be really careful. Kate has a team where we've worked on labeling all these data points. It's a lot of work. We're on it. It just takes time, and we want to do it right. We don't want to put something out there that is just going to kind of mess things up. We want it to improve reliability and accuracy, not take us back.
Excellent. That's exciting. When the timing is right, you have a standing invitation to come present to our community on how that is coming along. We look forward to that.
Thank you.
We do have just a few questions. I'll ask one more if that's okay. I want to be mindful of your time here. There's a few questions about Epic and how you can transfer the final MBS report into Epic.
Kate, I'm gonna let you take that one.
Yeah, and I'll preface it by saying, you know, initially we worked with Epic. Back in 2015 or 16, when MUSC adopted Epic, we worked with them to see if there could be this automated push like we have with TEMS. But needless to say, it was very complicated, a big endeavor, and was going to be very costly, not just to us, but to even clinicians who wanted to use it to write this code for every unique Epic at every institution. So that was not an option. But what we have done is ensured that if you're using a flow sheet, that's different. So if you're using drop-down flow sheets, it's not going to directly move over. That's coded data. But if you're using so like a smart phrase or a notes option, you can just copy and paste from that Word report, which you would download, and just put it right into Epic. Or if you upload media, you can upload a PDF report. At MUSC, I have a smart phrase that gives me like my specific header of things that's required by my institution. And then I copy and paste the MBSImP report directly in, and then I just have a place for my signature at the bottom. So everything is done on the MBSImP website for me at my institution, and it's a quick copy and paste. The head, the picture, all of that goes over as well.
Excellent. I appreciate that. Well, we will wrap things up here. Thank you, Kate and Bonnie, so much for joining us this evening. This was really enlightening and really, really, really interesting from my perspective. When we end here, there will be a survey that goes out. If you are interested in ASHA CEUs, it's required to complete the survey within the next week. If you have any questions that we didn't get to or any that you think of after this presentation, you're welcome to email the foundation and I can pass those along. And with that, I hope you join us for our next webinar, which will be on December 2nd, which is Giving Tuesday. And this will be for 0.2 ASHA CEUs that count towards your ethics requirement. And I'll send some information in the email that will go out. Thank you, everybody, for joining us. Kate and Bonnie, thank you again. We really appreciate it. And take care, everybody.
Thanks, Elizabeth.
Bye. Thank you.
Bye.